Today we are going to discuss a brief memory map of the acute respiratory failure from the book of Fishman. So let's first understand what a respiratory failure is. Now, respiratory failure is a condition in which the respiratory system fails in one or both of its gas exchange functions. Either there is a problem with oxygenation or there is a problem with the elimination of carbon dioxide from the venous blood. Now, broadly speaking, we divide the respiratory failure into two parts. We have the hypoxemic respiratory failure and then we have hypercapnic respiratory failure. By definition, hypercapnic is something where the PaCO2 or the arterial CO2 is more than 45, and hypoxemic respiratory failure is a decrease in the arterial oxygen pressures of less than 55 when the FiO2 is more than or equal to zero point 0.6. Now, each of these categories, hypercapnic and hypoxemic, each can be divided into acute and chronic. Acute generally presents as a life-threatening derangement in the ABG or in the acid-base status of the patient, whereas chronic has a more indolent and maybe clinically inapparent in a patient too. Now, as we have said that hypoxemia and hypercapnia, both of them can be further divided into acute and chronic. So let's first understand what a hypoxemic respiratory failure is. So whenever there is an abrupt change in the mental status of a patient, that denotes an acute event. One thing that is for sure that you should understand that the PaO2 here is less than 55 millimeters by definition when an FiO2 is zero point 0.6 or greater. As we said, it is further divided into acute and chronic. So acute happens when the patient presents with a abrupt change in mental status. Chronic, on the other hand, is when the patient has presence of markers of chronic hypoxemia. This could be either in the form of polycythemia or it could also present as cor pulmonale, right? Now, the major threat, as we all know in a case of hypoxemia, is not just the decreased oxygen content of the blood, but it is the inadequate tissue oxygenation, right? And this is reflected in tissue oxygen delivery. What is tissue oxygen delivery? This is nothing but the product of cardiac output and the blood oxygen content. Now, by this, we can say that the factors that lower the cardiac output or the hemoglobin concentration, or if anything, inhibits the dissociation of oxygen from hemoglobin at the tissue level, would promote tissue hypoxia without technically producing respiratory failure. So, this patient might not have a respiratory failure, but since his cardiac output is low, or if there is some problem with the hemoglobin, or if there is an issue where a hemoglobin is not able to dissociate from oxygen, that can lead to a tissue hypoxemia, which essentially which may not present as a respiratory failure, right? On the other part, when we talk about hypercapnic respiratory failure, here it could be, like we said, further divided into acute and chronic. Acute is when the raised CO2 levels are accompanied by acidemia, that is a pH of less than 7.3. Chronic, on the other hand, would present to you obviously with an elevated PaCO2, but since the body has compensated for it, so as a result of renal compensation, you would find an increase in the serum bicarb levels, right? So this is it. But remember that there are many cases where you may find a mixed picture. That is, you may find both a hypercapnic as well as a hypoxemic type of respiratory failure, right? So now let's understand this from a different perspective. We know that the basic function of breathing consists of an intricate network of functioning of various organs in our body, right from the central nervous system to the intercostal muscles to the lungs, right? So we call this as effector components. So the effector components are CNS, peripheral nervous system, that is PNS, respiratory muscles, and chest wall, airways or alveoli. So if you take a look at the first four components, that is the CNS, the PNS, respiratory muscle, and chest wall, this constitutes what we say as the respiratory pump. Failure of the respiratory pump leads to hypercapnia. Now, hypercapnia or hypercapnic condition is generally, now how do you calculate this? Now, VA, as we all know, how do you calculate the PaCO2? Now, PaCO2 is calculated by this formula, that is VA, that is minute alveolar ventilation, into equals the constant multiplied by the rate of CO2 production. Now, in normal circumstances, if we consider that the CO2 production is constant, we can say that the PaCO2 kind of depends on the minute alveolar ventilation, which further depends upon the minute ventilation and the relationship between VE and VA. So, indirectly, what we can say is that the minute ventilation depends upon the utilization, that VO2, that is the oxygen utilization, VD by VT ratio, that is where VD is the dead space and VT is the tidal volume. So we can say that whenever you have a condition where there is an increase in the dead space, or when there is a decrease in the tidal volume, these conditions can result in hypercapnia. Remember that. On the other hand, if we have a problem in the last two components of this effector, like we said, the airways or the alveoli, if we have a problem here, then this may lead to a hypoxemic type of a respiratory failure, right? Now, hypoxemic respiratory failure could be as a result of many problems. There could be an alveolar hypoventilation, there could be some VQ mismatch, there could be a shunt, or there could be some diffusion limitation. Diffusion limitation is easy to understand. Something wrong with the transport across the alveolar capillary membrane can lead to this. When we talk about shunt, what we're trying to say is that the venous blood bypasses a ventilated alveoli, resulting in a venous admixture. VQ mismatch is a condition where the areas of low ventilation are there relative to the perfusion. Now, this contributes to hypoxemia because the blood is not getting oxygenated. Another reason of alveolar hypoventilation are the various neuromuscular disorders, right? So, interestingly, in neuromuscular disorders, you generally have a normal AA gradient, right? So, there is a huge big formula for AA gradient. We can calculate it later on. Uh, yeah, that suffices the purpose. Now, after this, after understanding the effector components and its role, uh, the the categories of respiratory failure have been further divided. Now, as we said, this could be either due to some problem in the CNS, could be some problem in the PNS, could be due to some problem in the airways, or could be due to or it could be due to some problem in the in the alveoli, right? So let's talk about first the CNS, which is the top one, obviously. So anything now CNS, anything which causes a suppression of the neural drive, that can lead to this condition. Now, the suppression of the neural drive could be due to many reasons. This could be due to some narcotic which the patient might be taking, as in the case of methadone, which, if given for long term, can cause chronic hypercapnia. Could also be as a result of some metabolic derangements, especially in the case of severe myxedema or hepatic failure or an advanced type of uremia. The patient might also be suffering from a chronic metabolic alkalosis, which happens when the patient has been on long term diuretic use. Apart from that, there could be some structural causes which would lead to a suppression of the neural drive. This includes meningoencephalitis, some localized tumors, vascular abnormalities of the medulla, stroke, which is affecting the medullary control, any structural abnormality causing a dysfunction of the medulla or involving the medulla can cause this condition, right? Now, after from CNS, let's move further. Let's go to the PNS, that is peripheral nervous system. Now, peripheral nervous system causes could be further divided into either there could be some problem in the peripheral nerves, there could be some problem at the neuromuscular junction, then there could be eventually some problem at the chest wall level, that is at the muscle level, or there could be some pharmacological causes for this, right? So what basically happens in the peripheral nervous system problems, there is inadequate activation of the inspiratory muscles. So whenever the inspiratory muscles are not being activated properly, or if there is a limited thoracic excursion, the tidal volume falls, right? So while there is an increase in the respiratory rate in response to this, the minute ventilation still keeps on decreasing. So, as a result of all these, there is a reduced lung compliance. Whenever you have a reduced lung compliance, that further leads to a fall in the tidal volume and increases in the elastic work of breathing. That is elastic component. We have work of breathing. There are two components. There is an elastic component and there is the resistance component. So, the elastic component is decreased by a decrease in the compliance. Hence, the ventilatory supply becomes limited while the ventilatory demand increases. This happens due to a rise in the VD by VT ratio. Now, before we jump onto this, I just want to just acquaint you with what is a ventilatory supply and what is a ventilatory demand. Now, when you talk about ventilatory supply is nothing but it's the maximal spontaneous ventilation that can be maintained without development of respiratory muscle fatigue. This is also known as maximal sustainable ventilation. Ventilatory demand is simply a spontaneous minute ventilation, which, when maintained, leads to a stable PaCO2. That is, there is a fixed CO2 production at this rate. So, the there has to be a balance between ventilatory demand and the ventilatory supply. In normal circumstances, the ventilatory supply is much more as compared to the ventilatory demand. How do we say it? As a general rule, the ventilatory supply is approximately one half of the maximal voluntary ventilation, right? So, by example, if we can say that a 70 kg adult uh, would have an MVV of 160 liters, right? And the MSV, that is the ventilatory supply, is 80 liters. But eventually, the minute ventilation is how much? 6 to 7 liters. So, on one hand, we have the ventilatory supply going to 80, and then we have the minute ventilation going to just 6 to 7. So, you can say that ventilatory supply is always more than ventilatory demand. Now, why is this important? Because in conditions where you need to increase the demand, right, that is in the case of exercise or an exertion, uh, uh, it doesn't really matter, and it really doesn't take a lot of energy for the body to increase its ventilatory supply. Matter of fact, it is not needed at all. And that is why in normal circumstances in exercise, CO2 production still remains constant. You don't increase the CO2 levels, if you're getting my point, right? So there could be now umpteen reasons of the problems with the supply. Now the factors, so remember the golden rule: any condition which causes either an increase in the ventilatory demand or a decrease in the ventilatory supply can cause a hypercapnic condition, right? So causes of increased ventilatory demand is includes anything that causes an increase in the VDVT ratio, the increase in the VO2, increase in the respiratory quotient, or a decrease in the PaCO2, right? So increase in the VDVT ratio is in the case of acute asthma, basically in any condition which is causing an increase in the dead space. Now this includes acute asthma, emphysema, late phase of acute respiratory distress syndrome, and pulmonary emboli. Then increased oxygen utilization. This is seen in fever, sepsis, trauma, shivering, increased work of breathing, and massive obesity. Increased respiratory quotient is seen whenever the patient takes excessive carbohydrate in the diet. Decreased PaCO2 could be as a result of hypoxemia, metabolic acidosis, and anxiety, sepsis, renal failure, or a hepatic failure. So these are the conditions which cause an increase in the ventilatory demand, right? Then there are certain conditions which cause a decrease in the ventilatory supply. Now, when we talk about a decrease in the ventilatory supply, when we talk about a decrease in the ventilatory supply, causes include decreased respiratory muscle strength. Now, this could be due to either a fatigue or atrophy. Fatigue causes include if the patient is recovering from a respiratory failure, or when the patient has a high respiratory rate, or if there is increased inspiratory time. On the other hand, this could also be due to disuse atrophy, as in the case of patients who are on prolonged mechanical ventilation following a phrenic nerve injury. Then this could also happen as a result of malnutrition, electrolyte abnormalities, especially a low level of phosphate or potassium, ABG abnormalities in the form of a low pH, low PaO2, or a high PaCO2, fatty infiltration in diaphragm as a result of obesity, or some unfavorable alteration in the diaphragm length tension relationship. That is, especially in the case of flattening of diaphragms, which we generally see in dynamic hyperinflations. Then this could also happen as a result of increased muscle energy requirement, or either the requirement is high or the supply is low, right? So in conditions when there is a high elastic work of breathing, this happens when there is a low lung or chest wall compliance, like we already discussed. Then resistance component of the work of breathing is increased in the case of airway obstruction. And finally, you have a reduced diaphragmatic perfusion in the case of shock or anemia, right? So when the supply is reduced, that is in case of shock and anemia. Then there could also be a problem in the decreased motor in the motor neuron function. Now, either there could be problem at the phrenic nerve level, or there could be some problem in the neuromuscular transmission. Phrenic nerve output के level पे problem could be polyneuropathy, GB syndrome, or a phrenic nerve transection injury, or a poliomyelitis. Neuromuscular transmission problems include myasthenia gravis or a use of paralyzing agents. Then abnormal respiratory mechanics. Now, abnormal respiratory mechanics include airflow limitation, loss of lung volumes, or some other restrictive defects. Airflow limitation is seen in bronchospasms or in upper airway obstruction, or whenever there is an excessive airway secretion. Loss of lung volumes can happen as a result of lung resections or large pleural effusions. Apart from that, certain restrictive defects, conditions, examples include pain limited inspiration, tense abdominal distension due to ileus, peritoneal dialysis, fluids, or ascites. So these are the conditions which cause a decrease in the ventilatory supply. So coming back to our discussion, so when we talked about the PNS problems, then CNS problems. Coming to the CNS, so now PNS problems could be, like we said, due to some peripheral nerve issues Could be at the level of neuromuscular junctions, which we just discussed. Uh, could be as a result of respiratory muscle fatigue and atrophy during prolonged weaning from mechanical ventilation. Then chest wall problems could be in the form of structural abnormalities, especially in the cases of kyphoscoliosis or in ankylosing spondylitis, or if the patient has undergone an excessive thoracoplasty or fibrothorax. Now, all these conditions, like we said, cause a decrease in the chest wall compliance and causes the elastic component of work of breathing to increase. Apart from that, flail chest can also be another example. So all these things cause a higher VO2. So whenever you have a higher VO2, that, like we said, is a, now high VO2, we just read about it. High VO2 is a condition which causes a increase in the demand, right? So it causes an increase in the demand, right? So this thus causes hypercapnia, right? Then apart from that, there could be certain pharmacological causes. Whenever you're giving some depolarizing and non-depolarizing paralyzing agents to a patient, or if the patient is undergoing a cholinergic crisis during therapy for myasthenia gravis, or if the patient has been given a long-term systemic corticosteroid. So all these conditions can lead to this. Apart from that, patient can also, end up having aspiration pneumonia and secondary hypoxemia as a result of impaired gag reflex as well, right? So these are the problems with the PNS. Now, after PNS, let's come to the problems at the airways. Now, airways, as we all know, are further divided into upper airways and lower airways. Upper airway problems could be in the form of acute epiglottitis, aspirated foreign body, certain tumors, or narrowing of the trachea due to any reason. Lower airway problems could be in the form of asthma, COPD, or host of other bronchiolitis or bronchiectasis as well. Now, lower airway problems. Now, this leads to air trapping and lung hyperinflation, which eventually leads to diaphragm flattening and worsening diaphragm function. When this happens, like we said, growing imbalance between ventilatory supply, and due to this problem, the ventilatory supply would eventually go down, like we just studied over here, right? Then, airway narrowing itself it results in a greater transthoracic pressure. Now, whenever there is a greater transthoracic pressure gradient, so I'm sorry, airway narrowing leads to a decrease in the inspiratory flow, like we discussed in the by the Poiseuille's equation. This causes an increase in the resistive component of the work of breathing, right? And this leads to increase in the VO2 again. And finally, due to all these problems, tidal volume falls and dead space rises. That is VD by VT ratio we basically talking about. That is also increased, and this leads to hypercapnia. After going for the airways, let's go further down. Then we talk about then going to the alveoli. Now in the alveoli, there could be a diffuse alveolar filling. Now, diffuse alveolar filling could be as a result of cardiogenic or non-cardiogenic pulmonary edema, diffuse pneumonia, extensive pulmonary hemorrhage, like happens in the case of diffuse alveolar hemorrhages, various causes, aspiration of stomach contents, and also near drowning. Sort of an ARDS picture, if we want to simplify it. Now, in this condition, there is a right to left shunt. What happens basically here? The demand increases. So whenever the demand is high because of hypoxemia, and also there is an increase in the VDVT ratio. So whenever you have an increase in the VDVT ratio, that means there is an elastic work of breathing is increased here. Both elastic as well as resistive work of breathing is improved, is decreased, is increased. Elastic work of breathing is increased due to reduced lung compliance, and resistive is decreased due to airway narrowing and increased airway reactivity, right? And at the same time, the neural drive to breathe is also increased. So, in conjunction with heightened ventilatory demand, the supply is reduced because of alveolar flooding. So, alveolar flooding ki wajah se the supply is reduced, right? And demand is already raised, right? So, that is why this eventually leads to respiratory muscle fatigue, and reduced blood supply also to the diaphragm exists, secondary to shock, right? So, these conditions eventually cause a respiratory failure, right? Now, after reading this, let's come to the management part of these. So we've studied about this. Let's talk about then the management part. Now, the management part includes four important points. First of all, you have to triage as to where the patient should be managed, whether ICU or non-ICU. You should search for an underlying cause, correction of hypoxia and hypercapnia, and airway management. So triage is very important. Now, triage depends upon firstly the acuity of the respiratory failure, the degree of hypoxemia, hypercapnia, acidemia, presence of comorbid conditions like if there is any cardiac disease or renal insufficiency, on and it also depends on the clinical direction that the patient takes over the first few minutes or hours of observation, right? Then Search for an underlying cause, obviously, by history and various other investigations. Then, how do you correct hypoxia and hypercapnia? Now, remember that the goal of correction is to assure adequate oxygen delivery. This happens when you have a target of 60 millimeters of mercury in your mind, assuming that the hematocrit and cardiac output is normal, or the patient is not having any kind of an anemia, or the ejection fraction is not low, right? In the patients, but in the patients who have coronary and cerebrovascular disease, a slightly higher level of arterial oxygenation target should be desired, right? This actually provides a buffer for any sudden or unpredictable change in the gas exchange, right? After that, choosing the airway management, choosing the right airway is very important, right? So airway management can happen either you put a patient on mechanical ventilation or the patient is on NIV. Now, intubation when is chosen when there is a progressive hypoxemia or hypercapnia over the first few minutes or hours of care, right? So you have put on patient on oxygen, but still the patient is not improving. The hypercapnia has deteriorated. So all these are indications of intubation, right? Non-invasive ventilation is generally used in acute hypoxemic respiratory failure or hypercapnia as well, if the patient's condition is permitted. But if the patient is suffering from respiratory arrest, ill-fitting face mask, hemodynamic instability, patient is not able to protect his airway, there are excessive secretions, right? There is some upper gastrointestinal surgery happen, or there is a facial trauma. In all these conditions, NIV would not be used, right? Of course, NIV can be helpful in facilitating weaning and early extubation as well. Now, after giving all these things, there could be certain complications as well, right? So, what are the complications of acute respiratory failure? Now, complications could be due to the mechanical devices that you use, or there could be some patient related problems. So, first, let's talk about the mechanical device issues, right? So, there could be a complication of mechanical ventilation, right? So, this could be in the form of infection, arterial desaturations, hypotension, barotrauma, and others. There could be some complications of insertion and maintenance of pulmonary artery catheters, like in case of pneumothorax, air embolisms, arrhythmias, infection, thrombosis, or pulmonary artery rupture. There could be some complications of tracheal intubation, for example, related to prolonged intubation attempt, like in case of hypoxemic, like if the patient, if the physician is taking too much time in intubating a patient, this can lead to a hypoxemic brain injury, cardiac arrest, seizures, etc., all due to prolonged hypoxemia. Then there could be then complications could be related to right main bronchus intubation. Accidentally, you might have intubated the right main bronchus. This may lead to hypoventilation, pneumothorax, as well as atelectasis. Uh, Self or inadvertent extubation, patient has extubated himself, endotracheal tube dislodgement, cuff leak, injury to pharynx, larynx, or trachea. Then problems could also occur in tracheotomy, like pneumothorax, bleeding, tube dislodgement, all these conditions. Gastro, then these were the mechanical device related problems. Then there are certain patient related problems. Firstly, there could be some problems in the pulmonary component. There could be pulmonary emboli as a complication, pulmonary barotrauma, which can happen in the form of interstitial emphysema, pneumothorax, subcutaneous emphysema, pneumoperitoneum, tension lung cyst, or subpleural air cyst, or pulmonary fibrosis could also take place. Gastrointestinal complications include hemorrhage, including stress ulceration, ileus, and diarrhea. Cardiovascular complications include hypotension, arrhythmias, decreased cardiac output, myocardial infarction, and pulmonary hypertension. Renal causes or renal complications include acute renal failure, fluid retention. Infectious complications include nosocomial pneumonia, bacteremia, sepsis, paranasal sinusitis. Nutritional complications include now complications of underlying malnutrition, right? So this could be in the form of decreased respiratory muscle strength, immune suppression, complications of enteral feeding, right? In the form of pneumothorax, pleural effusions, sinusitis, aspiration, or diarrhea. Complications of parenteral feeding. Includes pneumothorax, sepsis, hyperglycemia, hyperosmolar coma, hypophosphatemia, liver function test abnormalities, etc. Apart from that, there could be certain other causes like hematological in the form of anemia and thrombocytopenia, and psychiatric problems, that is in the form of an anxiety, depression, confusion, sleep dysfunction, and psychosis, right? Then, so we have intubated the patient, we have taken care of the complications. Now, let's understand the morbidity and mortality. Now, this could be different in both hypercapnic as well as in hypoxemic respiratory failure. While in case of acute hypoxemic respiratory failure, the morbidity and mortality entirely depends on the underlying cause. If there is a pre-existing problem that the patient has, then obviously this is a big problem. Then, apart from that, survivors of ARDS, they have persistent functional disabilities even after discharge, and there is an excessive muscle wasting and weakness as well. Hypercapnic patients have a morbidity and mortality dependent on various points. It could depend on the physiological reserves as determined by concurrent cardiopulmonary, renal, hepatic, or neurological diseases, and obviously the patient's age, underlying cause of the acute deterioration, severity of the respiratory failure as defined by arterial pH and PCO2, and development of complications after onset of acute failure, for example, sepsis, pneumonia, renal failure, or GI bleed, right? So, with this we end the discussion, and with this we end the discussion on this topic, and um, and well, yes, that's it. So, thank you very much.